Good morning, everyone. Thank you for joining the Department of Family Medicine and Community Health Grand Rounds. My name is Eric Gale, and I'm the President for Healthcare Services at the Institute for Family Health. Today's topic is evidence-based menopause management in a primary care setting, and we're pleased to have one of the leading experts on women's health, Dr. Elizabeth Poynor, Chair of Women's Health and Gynecology at Atria Institute, as she engages us in this subject matter. The Atria Institute and the Institute have a strong collaborative relationship where over the past 2 years, Atria has supported us providing blood pressure monitoring kits to our patients, and that has helped to engage patients in their own chronic disease management and has led to the Institute being one of the leading community health centers in the management of blood pressure. So we thank Atria and Dr. Poynor's group for supporting us. Dr. Elizabeth Poynor is a gynecologic oncologist and advanced pelvic surgeon who specializes in the management of midlife women's health, hormonal and endocrinological health concerns, and complex pelvic surgery. Dr. Poynor received her medical degree from Columbia University, completed her residency training in obstetrics and gynecology at the University of Pennsylvania, and completed her fellowship in gynecologic oncology at Memorial Sloan Kettering Cancer Center, where she continued to work as a surgical attendant until 2006. In 2006, Dr. Poynor established her own private practice in gynecologic oncology and pelvic surgery in Manhattan. She's currently a clinical professor of obstetrics and gynecology at NYU Langone and chair of women's health and gynecology at Atria Health, and performs surgery at NYU Langone Medical Center and Northwell Health Lenox Hill Hospital. Dr. Poynor has co-authored numerous publications and book chapters on topics in gynecology and gynecologic oncology. She has served as Director of Translational Research for the Gynecologic Service at Memorial Sloan Kettering Cancer Center and in leadership of the Committee on Experimental Medicine in Gynecologic Oncology Group, as well as an investigator in many clinical trials relating to the surgical, medical, and biologic treatment of gynecologic cancers. Dr. Poynor has had a lifelong interest in the role of hormonal health in overall well-being, menopause, aging, and complex gynecologic issues such as premenstrual syndrome, premenstrual dysphoric disorder, endometriosis, pelvic floor dysfunction, and polycystic ovary syndrome. She has developed an integrative approach employing not only traditional therapies, but also bioidentical and more natural therapies to enhance healing and quality of life. Dr. Poynor, thank you for joining us today.
Thank you so much for allowing me to speak about one of my favorite topics, midlife women's health and menopause management. So today I'd like to take you on a tour through menopause, both the symptomatology and physiologic changes that occur, because this really is an opportunity in a time of a woman's life to really gain a hold of her health. And as health practitioners, for us to really develop a holistic approach, including not only hormonal management through medical therapies, but also through more lifestyle types of approaches. So I hope to engage you in both of these types of approaches today. So I'm trying to change my slide here and it's not moving. So let's talk about what menopause is. So menopause is both a process and a time point in a woman's life. So menopause is defined as the permanent cessation of menstruation. So the final menstrual period, basically. Postmenopause is 12 months after the final menstrual period, and perimenopause is the time leading up to the final menstrual period and a year after the final menstrual period. The average age of menopause in the United States is about 51. It's not the same across all countries. High-income countries have a later age of menopause, ranging from between the ages of 45 and 55 years, with less than 45 being considered early menopause, greater than 54 or 55 being considered late menopause. And lower income countries actually have a lower age of menopause. Perimenopause has been really ignored in the medical literature and not really spoken about so much in many practices. Some practices it is, But this is the time where physiologic changes are beginning to occur. We always talk about menopause and postmenopause. Most of our research is dedicated to postmenopausal time period, but really perimenopause is the time where all these physiologic shifts begin to occur with fluctuating levels of estrogen. So perimenopause is defined as the time period leading up to menopause where ovarian production of estrogen and progesterone become erratic, and we'll talk about that in a little bit. Symptoms and physiologic changes may be more pronounced in perimenopause than postmenopause. So again, this is a time and an opportunity to really grab a hold of symptomatology and physiologic changes. Perimenopause is defined in the medical literature and in STRAW, or the stages of reproductive aging, as the onset of cycle irregularity through until 12 months after the final menstrual period. So a woman many times will begin to have shorter time between her periods, longer time between her periods, heavier periods or lighter periods, a little bit unpredictable during those perimenopausal years. And these years can start as early as 10 years before the final menstrual period. So they can start really between 40 and 45, and that's really under-recognized in the medical literature and many practices. So super important to realize that women are going to start to have symptomatology and physiologic changes of those hormonal fluctuations far before the final menstrual period. The stages of reproductive aging, I have a reference to this at the end of the talk. I put resources in here for you also. First came about in 2001. It's been later kind of validated and enhanced in 2010, but it really defines what perimenopause is based on either hormone levels or FSH levels, and also symptomatology. The late reproductive years are also a really interesting time, especially I have a big interest in these years because these are the time before we even have any menstrual irregularities. It's when fertility declines. And in women, we always talk about fertility declines at the age of 35, but we don't talk about the physiologic ramifications of those things that are causing fertility decline. So between 35 and 45, estrogen levels, although not measurably lower, can become lower or more erratic. And this is also a time from 35 on where women will also begin to have symptomatology. Factors associated with the age of menopause. Hysterectomy can lead to an earlier age of menopause. Smoking, lower levels of education, living at an altitude above 2,000 meters, medical conditions such as HIV, Turner syndrome, Fragile X, autoimmune issues can also lead to an earlier age of menopause. Of course, induced menopause through chemotherapy or radiation therapy or galactosemia. Later ages of menopause are associated with a later age of menarche, higher number of children, a higher body mass index, oral contraceptive use, better self-rated health. The age of menopause also tends to be familial. If you have a woman in your practice who has, my sister went through menopause quite early, then that should be on your radar screen a little bit about thinking about this patient if she starts to have some complaints also, or mothers. Employment also it correlates with the age of menopause. So as I said before, menopause is not only an event, it's a process. And the process is really important because this allows us to really impact on the physiologic changes which occur, the quality of life that women will experience, and the later health outcomes that they will also experience as they age. So the event is the final menstrual period, which occurs when ovulatory-related function of the ovary ends. And the process is that perpetual loss of follicles, resulting in a winding down of reproductive hormones and ovarian aging, corresponding with the classic signs and symptoms of menopause. So the ovary contains a finite number of oocytes, and there's an orderly attrition of those oocytes during life. At 20 weeks gestation, there are about 6 to 7 million oocytes in the female ovary. At birth, this has dropped down to 1 to 2 million oocytes. At puberty, there are 300 to 500,000 oocytes. During the reproductive years, we will ovulate between 4 and 500 oocytes. And then by menopause, there are only 300 to 400 oocytes left, and many of those are incompetent. And when those oocytes become atretic and we don't have any left, our estrogen levels decline. Prior to that, FSH and estrogen can become very erratic, actually, as the ovary ages. And this shows you, and this is important to realize, that there are actually 4 different types of perimenopause, or 4 different patterns of estrogen declination in those years leading up to menopause. And this can sometimes be totally confusing for patients and the providers who are caring for them. During perimenopause, or 10 years before menopause, the progesterone levels steadily decline. So that's not even on this graph, because that's a pretty steady decline. The luteal phase becomes a little less efficient, progesterone levels decline, luteal phase may be shorter, but estradiol levels may actually go up, and you see the top arrow that estrogen levels may go up and then decline rapidly for some women. They may go up and decline a little bit more slowly. And for some women, they'll experience a very slow decline of estrogen leading up to the final menstrual period. And this is super important because those symptoms of perimenopause can either be estrogen excess symptoms or symptoms of declining estrogen and progesterone. And this is where it gets a little messy and confusing. And I think this is where a lot of people step back and say, I don't understand this. But what happens for some women in the perimenopausal years, they'll experience estrogen excess symptoms as their FSH goes up and their estradiol goes up and down and somewhat erratic. I always call this a time period where it's like taking a mirror and shattering it on the floor with shattered glass in terms of the symptoms. But intermittent symptoms may be breast tenderness, menorrhagia, or heavier periods. Migraines may get worse. Nauseousness may get worse with estrogen excess. There may be a shorter cycle length and a shorter follicular phase, and of course, worsening of PMS. Worsening of PMS is a very classic symptoms in the perimenopausal years leading up to the final menstrual period. Symptoms of declining estrogen and progesterone are the ones that we all pretty much know about probably, but vasomotor symptoms or hot flashes. These can also be described as I'm sweating at night or waking up at night, so night sweats. Urogenital symptoms including vaginal irritation, itching, burning, dryness, dyspareunia, and then urinary frequency resulting from vulvar and vaginal atrophy, urgency, and many times recurrent urinary tract infections. Vasomotor symptoms are by far the most common symptoms that are reported in the literature related to declining estrogen. This may change actually, because we've really, in the past, we were really distilling women down into vaginal dryness and hot flashes, but we realize that there are many other symptoms and signs of menopause and declining estrogen. So about 80% of people, or up to 80% of people, will experience vasomotor symptoms, and this is across the world. This is not geographically dependent. It's not economically dependent, but up to 80% of women across the world will experience hot flashes as estrogen levels decline. Again, the genitourinary syndrome of menopause, which is basically vulvar and vaginal atrophy leading to urinary and vaginal health changes, can impact up again to 80% of women. And this is one that always gets worse. If it's bad, it only gets worse. It never gets better. Hot flashes can get better as we transition through menopause, but vulvar and vaginal atrophy never get better. They usually get worse. And of course, then changes in menstrual cycle. Women, when they have leading up to the final menstrual period, will have a longer time between their periods. They may have a shorter time between their periods. They may have heavier bleeding. They may have lighter bleeding. Other symptoms of declining estrogen, which you will really hear if you really listen to your patients, include weight gain or shape shifting. Typically, women will gain 5 to 7 pounds in the years leading up to menopause, and this may be at the rate of 1 to 2 pounds per year. And then after menopause is transitioning through menopause, they may have realized they've gained up to 10 pounds. Some may gain up to 15 pounds through the menopausal transition. But almost everybody complains. Not everybody has weight gain, but almost everybody complains of shape shifting. So people will complain, my waist is thicker, I have more weight in my abdomen, and this is because of deposition of visceral fat. As estrogen levels go down, we deposit more visceral fat into the abdominal compartment. Mood disturbances are also common. People are really beginning to pay attention to this. In the past, I remember in 2012, when I was experiencing some mood disturbances, the North American Menopause came out and said, absolutely, mood is not related to hormone levels, but it is. We know it is now. Depression and anxiety can get much worse. And as I'll talk about in a little bit, that these tend to be more socially isolating behaviors. Sleep disturbances, of course, can get worse. Poor sleep quality is reported. And I always say between the hours of about 2 o'clock and 4 o'clock, you can look out over the boroughs and see probably a lot of lights on of perimenopausal women and menopausal women who are awake at 2 to 4 o'clock in the morning. There seems to be something with circadian rhythms and melatonin, and that awakening literally at between 2 and 4 o'clock with lower estrogen levels. Cognitive changes are common and commonly reported and are being increasingly recognized. We call it brain fog. Some women will report some temporary cognitive dysfunction, including difficulties with memory and concentration. I find that word finding difficulty is prevalent in the perimenopausal years. So I'll always ask people, are you having any problems searching for the right word or remembering names? Executive function can also be off. Women will also report symptoms and signs of ADHD. Joint aches and pains are also become more prevalent as estrogen levels go down, not well recognized in the past. There is now the musculoskeletal syndrome of menopause, which is being reported on, and I'll talk about that in just a moment. Lower libido can also be experienced by many women in this transition. And this is what we see in the late reproductive years. Women will complain of shape-shifting, lower libido, and actually some vaginal dryness in those late reproductive years leading up to those perimenopausal years. Other symptoms which have been reported and are linked to perimenopause, but can have many other etiologies, but always hormone levels should be considered, or hormone fluctuation should be considered in patients who are at midlife complaining of increasing fatigue. Palpitations are not uncommon as estrogen levels drop. Hair loss, of course, on the head or hair growth on the face. Frozen shoulder, actually GI disruption and microbiome disruption. As estrogen levels fall, we have a more male gut microbiome, which is less diverse. GI disruption can include either diarrhea or constipation, which can occur with fluctuating estrogen levels. Tinnitus, skin changes with skin dryness, dry eye, gum disease can become more pronounced. Muscle loss, as we lose estrogen, we have more visceral fat deposition and we lose muscle. That's also as we lose testosterone. Burning tongue can also be a symptom of perimenopause and menopause, and histamine sensitivity with new onset of hives can also be seen during these years. So there's significant health consequences of menopause. And again, this is really the time period where we can really grab a hold of women's health and help them to age in a really strong fashion. So as estrogen levels decline, there's an increased inflammation in the body, and there's increased central abdominal fat deposition. And this leads to insulin resistance or an elevated risk of type 2 diabetes. So you'll see in the perimenopausal transition, you'll see like, oh, the hemoglobin A1C just took a pop up, but the patient is eating and exercising as she's always been doing. And that is reflective of this insulin resistance that does develop as estrogen levels decline. Cardiovascular effects of estrogen fluctuations are also prevalent. Estrogen is both anti-inflammatory and has antioxidant functions both. This lack of estrogen can lead to impaired endothelial function and a shift to a more adverse lipid profile. And this impaired endothelial function eventually leads to atherosclerosis and elevated blood pressure. So, I was looking up at the guidelines for checking blood pressure, and I found one guideline that said check a blood pressure every 2 years. And I was actually horrified. This is a time period during these perimenopausal and menopausal transitions where we really need to be paying attention to blood pressure much more carefully. And actually, glad to see the blood pressure initiative at Atria because super, super important for midlife women. Skeletal health, we know about. There's accelerated bone loss, which commences prior to the final menstrual period, leading to increased fracture risk. And this lower bone mass can also contribute to sarcopenia later in life. Neurologic, of course, we talked about a little bit. Some women may experience trouble with verbal memory, and this may also get better in the postmenopausal years. So there's metabolic disruption and disarrangement at the time of perimenopause and menopause. And this is one of the larger complaints that women just gain weight. And I'm just doing the same thing that I always did. And I'm eating well, I'm exercising, I'm paying attention to my stress management, but I just can't lose weight. In the early perimenopausal time period, energy expenditure actually declines by about 300 kcals per day. So there's metabolic shifts that decrease our energy expenditure at our basal metabolic rate. There's a change in substrate utilization, metabolic inflexibility ensues. Appetite is increased through some of our ghrelin and leptin insensitivity. Energy intake will also many times increase during this time period, maybe due to stress or other issues. This leads to increases in body fat and loss of lean body mass. And this leads to, when we increase our visceral fat deposition, chronic inflammation, insulin resistance, dyslipidemia, and cardiovascular dysfunction but by the time that many women get to menopause, over 30% will actually have metabolic syndrome. So that's a huge number of people who previously didn't have any issues. This slide just shows, and I leave it there for reference. It's hard and messy to look at right now, but it really just shows you that there is an orderly transition of physiologic changes from premenopause to postmenopause. And this is what you really need to pay attention to and be aware of. Look out for metabolic syndrome in those perimenopausal years. Think about increase of cardiac atherosclerotic disease, increased arterial stiffness, and increase in blood pressure, and changes in body habitus that lead to these adverse events. So there is an orderly transition to this that we can capture, and we can intervene through nutrition, lifestyle, and other medical management options. Be aware of the woman who has significant vasomotor symptoms and realize that this may be an independent cardiac disease risk factor. Endothelial dysfunction has been shown to worsen with an increased severity of vasomotor symptoms. There's a twofold increased risk of coronary heart disease in women who have frequent vasomotor symptoms. And the presence of vasomotor symptoms has been linked to adverse lipid profiles, increased insulin resistance, and elevated risk of hypertension, all of which occurred independently of changes in body weight. So significant vasomotor symptoms tend to be an independent risk factor for cardiac disease, and actually maybe also dementia and brain health issues. People are beginning to look at that and talk about that also. Sleep disruption due to vasomotor symptoms can also lead to an elevated risk of cardiac disease, as well as depression. Actually, if somebody's not sleeping or they're having mood issues, this is also independently linked to an elevated risk of cardiac disease. So the impact of perimenopause and menopause on physiology is usually multifactorial, not just one issue. Musculoskeletal health, of course, changes, as we mentioned before. Osteoporosis will affect 1 out of every 3 postmenopausal women, and the menopausal transition is really a key period to talk about bone health with women. There is a orderly decline in the lumbar spine of about 2.2%, mean annual decline each year around perimenopause and up to 3 years after the final menstrual period. And the femoral neck will also decrease by 1.8%. So this is really a time to focus on exercise, nutrition, and other interventions as needed. Most recently, the musculoskeletal syndrome of menopause has been described. More than 70% of women will experience musculoskeletal symptoms during perimenopause and menopause, and 25% will be disabled by them through the transition from perimenopause to postmenopause. This is collectively called the musculoskeletal syndrome of menopause. It consists of arthralgias, loss of muscle mass, loss of bone density, and progression of osteoarthritis. So in the past, we've spoken mainly about bone density, but we also know that there are many other issues which occur in the musculoskeletal syndrome of menopause. The brain has well-defined changes at the time of perimenopause and menopause. This is an active area of research right now. Dynamic MRI imaging has shown that regional gray matter volume decreases. There's altered spontaneous brain activity, particularly in regions related to cognitive function and memory. There's decreased perfusion of the brain during perimenopause. Energy metabolism also shifts. The brain uses glucose poorly as estrogen declines, and there's reduced glucose metabolism in the brain, and there's lower mitochondrial efficiency in the perimenopausal brain. This can lead to cognitive and mood changes, and neuroinflammation, leading to deficits in verbal memory and an increased risk of depressive symptoms. And most recently, Dr. Mosconi and her colleagues have shown that as a woman transitions through perimenopause, the number of estrogen receptors actually go up in the brain. So it's like the brain is hungry for estrogen. So this is really an active focus of investigation right now. So, care of the midlife woman or menopause actually screams out for holistic care because we need to pay attention to physical functioning and physiologic changes, some of which are menopause dependent, some of which are menopause and just aging dependent. As I said before, social structure is really, really important. Relationships may become stressed during perimenopause and menopause. This can lead to social isolation. And also, menopause may affect negatively sexually and interpersonal relationships. Economic issues at the time of perimenopause and menopause are super important to address. And now there's a whole initiative of addressing menopause in the workplace. There was an Irish nurses health study that came out that showed that 69% of women had disruption in the workplace due to menopausal symptoms. Many did not seek promotion, and there were many sick days and many lost work days due to menopausal and perimenopausal symptoms. So there is a large initiative right now to begin to educate employers on how to support women during this time period. Of course, there are psychological issues, both of which are hormone dependent, some of which are hormone dependent. There may be there may be relationship issues and also children leaving the home and just a shift of life at midlife. And that is like a perfect storm for a woman, that she's having a shift in her social structure and also a shift in her physiology. And again, that can lead to a perfect storm. So we really need to support women across all of these areas in a holistic fashion to really give them the proper medical support and social support that they need. So modern menopause management not only addresses symptoms, because in the past we had reduced menopause down to, are you having any vaginal dryness? Are you having any hot flashes? But we also need to look at the health risk, as I've outlined. Symptoms addressed go far beyond hot flashes and vaginal dryness. They include mood, cognitive issues, sexual health issues. We need to assess the utility of menopausal hormone therapy, both local and systemic. And of course, we need to look at lifestyle adjustments, including nutrition, anti-inflammatory nutrition, Mediterranean diet, exercise with good aerobic and anaerobic strength training exercise, sleep management, stress management, looking at workplace issues and community issues. And I highlighted communication here because this is really highly personalized medicine. And you really, when we make an intervention or a recommendation, we can't say, oh, just go try this and I'll see you back in a year. We really have to communicate with the people that we're helping and have ongoing outreach in terms of how's this impacting you? Is it helping you? Because it's such a unique time in the physiologic structure in terms of some people have no symptoms or no physiologic changes, but many or most will have some, and the combination may be unique to that individual. The health assessment of midlife should include a history, and I've always put a narrative. I always talk to people and say, you know, how are you feeling? Could you feel better? And that's a really important question that we need to ask. We need to, of course, look at cardiovascular disease risk, blood pressure and lipids, metabolic, looking at the waist to hip circumference, which is really replacing BMI. So just measure the waist and measure the hip and look at that circumference. And if it's too big, that's not good. Fasting blood glucose and hemoglobin A1C need to be looked at. Of course, we need to ask our patients about urogenital and sexual health. Many patients won't give us that information voluntarily, that we need to prompt them and ask them about it. And it's really important because a lot of women will suffer and not tell you that they're having dyspareunia. And then if we identify this, we can consider local and non-hormonal local therapy, both hormonal and non-hormonal. And it's also important to ask women about urinary frequency, vaginal burning, urinary tract infections, of course. This is a great opportunity to have a structured mental health screening at this time, because this is a time in women's lives where they're extremely susceptible to anxiety and depression. Cancer screening, of course, including breast, cervical, and colon cancer screening, and then really addressing this lifestyle and screening interventions. Patient narratives. So how do we diagnose menopause? Patient narratives are really important, right? Because we're early in menopause, we're not going to see any changes in hormone levels. We may not even see any changes in menstrual patterns, but we may hear, oh, I'm gaining weight in my midsection. I can't lose it. My mood is off. I don't feel well. I'm waking up at night. You get a collection of these symptoms and you start to think, it may be perimenopause. Of course, if somebody is not having a period and the diagnosis is uncertain, we should rule out pregnancy, hyperprolactinemia, thyroid disease, and hypothalamic amenorrhea. We should also exclude other common causes of fatigue and mood changes and hot flashes, of course, including thyroid disease, iron deficiency, type 2 diabetes. And then hormone levels may or may not be useful. Hormone levels may be useful after the final menstrual period or the couple of years leading up to the final menstrual period. You may see an FSH that is elevated, but many times the estradiol will be fine. And in that early perimenopausal transition, definitely the FSH will be normal for most people and estradiol level will be normal. So just because the hormone levels are normal doesn't mean that somebody is not beginning to transition through perimenopause. So how can we manage the symptoms and physiology of the years leading up to the final menstrual period? There's medical therapies, both hormonal and non-hormonal, and of course, lifestyle therapies, which include supplement herbs and others, along with community support. So just looking to menopausal hormone therapy, I want to take you through a quick tour of this. And this again can give you the basics and the foundations of this, because this is a great option for the vast majority of women who are under the age of 60 or less than 10 years after their final menstrual period. The FDA indications currently for menopausal hormone support or hormone therapy with estrogen plus or minus progesterone include vasomotor symptoms, moderate to severe, genitourinary symptoms of menopause, which is vaginal dryness, vaginal burning, vulvar dryness, vulvar burning, urinary tract infections, which are recurrent, or dyspareunia. Prevention of osteoporosis for the woman who's entering into menopause with a low DEXA score or higher risk of fragility fracture. Estrogen is a good option. And then, of course, the treatment of premature ovarian insufficiency. So POI or POF, premature ovarian failure, is defined as menopause before the age of 40. This may be induced through chemotherapy, radiation therapy, or surgery, or may be naturally occurring. These women all should be treated with estrogen and progesterone if there's no contraindications up until the age of 50, at least, to prevent cardiac and metabolic issues. Indirect effects which can be considered for hormone support include mood issues, sleep issues for the woman who has disrupted sleep, joint issues, joint pain, sexual health issues, and cognitive issues. So some basics. Menopausal hormone therapy is the most effective strategy to manage moderate to severe hot flashes and night sweats. Women with an intact uterus always require an approach of combined progesterone and estrogen therapy. If you give estrogen alone, that will lead to precancers of the uterus and then ultimately to cancer of the uterus for many people. Whereas those women without a uterus can use estrogen alone, and I'll talk about the reasoning for that in just a moment. Menopausal hormone therapy may have cardioprotective effects for women less than the age of 60 who are within 10 years of menopause. So that's our basic cutoff. Currently, it's not recommended to be used for the express purpose of cardiovascular risk reduction. That may change. That's an evolution a little bit, but our guidelines really support not using estrogen in a prophylactic type of or preventative type of fashion. But again, that might change. So the Women's Health Initiative trial is the trial that really changed how we approach menopausal hormone therapy. Prior to the publication of the Women's Health Initiative trial in 2002, basically everybody was handed, or many people were handed, a prescription, especially when I was at Sloan Kettering, when I took out ovaries, that here, go take this estrogen because it's going to help you to prevent cardiac disease. But in 2002, this came to a screeching halt when the Women's Health Initiative study was published. This study, although it is one of our largest randomized controlled trials, should never be used, however, to deny a woman estrogen. And I'll go through that in just a moment. But this clinical trial consisted of 27,000 postmenopausal women between the ages of 50 and 79. So many of them were far beyond the age of 60. And it randomized women to placebo or estrogen plus progestin, called Prempro. So estrogen derived from pregnant mare's urine and progestin called Provera, or an estrogen alone. So women who didn't have a uterus were randomized to estrogen alone, and those who had a uterus were randomized to estrogen plus progestin plus placebo. So what this study showed us is that estrogen was very effective for managing hot flashes. They decreased by 64% in the estrogen plus progestin arm. Effective at preventing diabetes, there was a decrease of 14 to 19% in both arms. However, stroke and DVT were increased in this study, as well as breast cancer. So estrogen plus progestin, so synthetic progestin, increased the risk of breast cancer by 25%. Estrogen alone, however, decreased the risk of breast cancer. So something bad with the progestin used in this study. Of course, gallbladder disease increased by 50 to 60%. Joint pain actually decreased during treatment, and bone health, there was a decreased fracture risk. So after 5.2 years of follow-up, the study was stopped because of the test statistic of the increased risk of developing breast cancer. And this put hormone therapy to a screeching halt in this country. And everybody was basically taken off of their hormone therapy. However, subset analysis, which was published later, showed that all-cause mortality was decreased in women by 30%. And if you looked at that subgroup of women between the ages of 50 to 59 years. So what this showed us, and most of this decrease in all-cause mortality was thought to be due to cardiac disease. So lower risk of cardiac disease, lower risk of death if you were prescribed estrogen within 10 years of menopause or between the ages of 50 and 59. So that's led us to this period where hormone support will actually be protective of cardiac health. And this just goes to show, this slide shows that up to probably about 40% of women were on hormone support prior to 2002. And when this study was published, it has dropped down to like 4 or 5%, and it remains at 4 or 5%. I think it's increasing now, but it really took hormone support kind of off the options for women for management of menopause. But we know that the type of progesterone matters, or progestogen matters, when we are prescribing hormones therapy. We now use natural progesterone, and we don't use synthetic progestins. So the risk of breast cancer with natural progesterones in our newer preparations is actually null. It doesn't increase it. However, if we use estrogen plus a synthetic progestin, Provera, norethindrone, or others, the risk of breast cancer is elevated. Estrogen delivery matters. If we use transdermal estrogen, the risk of stroke, DVT, and pulmonary embolus is not increased. Multiple studies have shown that the use of transdermal estrogen, either in gels or patches, does not increase the risk of stroke, DVT, or pulmonary embolus. We also know that timing of hormone support matters. And we know that if we can catch women in those early perimenopausal years, or those late perimenopausal years, early postmenopausal years, that we can prevent atherosclerotic disease. But once atherosclerotic disease is set up, estrogen doesn't help it. Primary treatment trials have shown that, actually. So that sweet spot is within 10 years of menopause or prior to the age of 60. So this critical window of hormone therapy has also translated into brain health. And now people are beginning to really look at this and talk about this, that if we use hormone therapy between far before 10 years, but within 1 to 3 years of the final menstrual period, that we probably get some brain protection. This remains a little controversial. People are bantering about this literature and data right now. And but it does look like hormone therapy is protective against dementia and is good for brain health if initiated between 1 and 3 years. But the data is just not strong enough for policies on prescribing to change yet. Hopefully that will change in the future. So candidates for hormone support include those who are less than 60 or less than 10 years after menopause, severe symptoms with symptoms with vasomotor symptoms, mood disruption, sleep disruption, and cognitive function issues. Some women may have a personal preference to use menopausal hormone therapy. These are candidates for hormone support. Women with bone density concerns with no contraindications. The contraindications to menopausal hormone therapy include undiagnosed vaginal bleeding, a stroke within the past 12 months, an MI within the past 12 months, severe liver disease, porphyrias, estrogen-dependent neoplasias, including breast cancer and some endometrial cancers, active or previous DVT, and I put previous DVT plus minus on that because if you've had a provoked DVT in the past, estrogen therapy sometimes can be prescribed for women with or without anticoagulation. And women who have protein C and S deficiency probably shouldn't be prescribed hormone support. And there's a little bit of data to support transdermal therapy in these women, but it's, again, not widespread use. Prescribing essentials, very basic. Transdermal estrogens are always preferred. They avoid first-pass hepatic metabolism and avoid clotting risk and some cardiac risk of oral estrogens. And women who have risk factors for cardiovascular disease who are obese should always have the transdermal route applied, but everybody should probably be prescribed a transdermal estrogen up front. Breast cancer risk was significantly reduced in the WHI study with estrogen alone, so that if you don't have a uterus and you're not having major sleep problems which respond to estrogen, then estrogen only may be better in terms of breast health. There are some women who will still need progesterone to help with sleep. Breast cancer risk may be influenced by choice of progestogen and hormone therapy regimens, and natural progesterone or prometrium is always preferred over synthetic progestins. So the contemporary approach to hormone therapy is evaluate the age, time since menopause and symptoms, and look at ASCVD risk scores. Actually, if the ASCVD risk score is less than 5% and there's less than one cardiovascular disease risk factor, hormone therapy may be considered. If the score is between 5 and 10%, or there's a low risk, however, greater than 2 risk factors, you can consider menopausal hormone therapy. It's not recommended, however, to start hormone therapy with an ASCVD risk score greater than 10%. So use a risk calculator, look at the ASCVD risk scores, look at the cardiac risk factors, and then you can make decisions on whether this patient is a candidate for hormone support. And I have a protocol and algorithms attached in the resources here, but because there's a couple of them from both Canada and Australia, which are really great to look at this. So in looking at women who have a history of hypertension, these women can be treated with hormone support. Transdermal hormones, estrogen and oral progesterone does not increase blood pressure, but recommendations are for women with hypertension that blood pressure must be well controlled. We need to consider the overall CVD risk. Transdermal estrogen is preferred, and natural progesterone is preferred over synthetic progestin. And you'll see that's just repetitive throughout this talk, and that these are the optimal ways to support hormones. Obesity is also not a contraindication, actually, to hormone therapy. Estrogen will help to preserve lean body mass, reduces visceral adiposity, and there's a lower risk of cardiovascular disease and related mortality with transdermal estrogens. So again, transdermal estrogen over oral estrogen, and natural progesterone over synthetic progestins in this group of women also. Diabetes is also not a contraindication, and actually estrogen and progesterone will decrease the risk of developing diabetes. Hormone therapy reduces the HOMA-IR by 13% and the risk of type 2 diabetes by 30%. And women who actually already have type 2 diabetes, estrogen can reduce the HOMA-IR by 35%, as well as instill improvements in other cardiovascular disease risk factors, including lipids, blood pressure, and inflammatory markers. So recommendations for women with diabetes are don't avoid hormone therapy, but individualize. The transdermal route is preferred, and progesterone has a minimal impact on glycemic control. This just shows the estrogen preparations. Again, I have this more in for reference for you. Actually, there are patches, gels, pills, and rings. We usually start with a patch, either a 2 times a week patch or a 1 time a week patch, dose escalating. Progesterone preparations, prometrium or oral progesterone is preferred in the dose of 100 to 200 milligrams. You can use the dose of 200 milligrams on cycle, 14 days a month, or 100 milligrams daily. Usually I recommend to use 100 milligrams daily or 200 milligrams daily for the woman who's having significant sleep disruptions, because this can be super helpful. Combination preparations are generally not recommended. The transdermal combination preparations have synthetic progestins in them. Remember, bad for the breast. And the oral combination, the other combinations with the natural hormones are actually contain an oral estradiol, which we also try to avoid. But some women may actually prefer an oral estrogen. Oral estrogens have the advantages of being convenient. They have reliable absorption for most users. The disadvantages are an increased risk of venous thromboembolism and cholelithiasis. There's also an increase in the thyroid binding globulin, so you have to pay attention to T4 levels, and you may need to adjust T4 dosing for women who are hypothyroid. And also oral estrogen may increase triglyceride blood levels, so adverse impact on lipid profiles. Transdermal estrogens have the advantage of the convenience of changing a patch once or twice a week. They avoid first-pass metabolism. There's no change in thyroid binding globulin. They, of course, have a null effect on hepatic coagulation proteins and a neutral effect on blood lipids. Disadvantages is they may cause irritation to the skin, and absorption may be poor. So many times we end up checking blood levels for women who are on transdermal estrogens. Communication is the key to success when prescribing estrogens. Optimally, women using systemic menopausal hormone therapy should have a medical review at 3 months to assess their symptom relief and side effects. Long-term follow-up should be at least yearly. Many times I'll speak to my patients at least every 6 months, 3 months while we're doing dose adjustments, and sometimes at 6 weeks. Unscheduled or prolonged bleeding 3 to 6 months after starting hormone therapy needs further investigation and should be referred to a gynecologist for a pelvic ultrasound and possible endometrial biopsy. So treatment tips: if symptoms persist on moderate to high doses, check serum estradiol levels for absorption. Not all women absorb estrogen the same way. When a patient does not respond to adequate dose therapy, another cause for the symptoms should be sought. So if the estradiol level is over 50 and a patient's still having symptomatology, look for other causes and origins of that symptomatology. Counsel and communicate, super important. Tee your patients up to understand what the initial symptoms may be when they're starting hormone support so they don't get scared. Breast tenderness, maybe a little bit of abnormal bleeding. When first starting up, maybe a little bit of nauseousness, a little bit of pelvic cramping. But because many women, once they start to have some symptoms, will say, oh, I'm not going to do that. And it just means we haven't communicated with them properly about what the potential side effects are when first starting. And many times these side effects will calm down after a month or two. Local treatments are necessary for and desired for many women with or without systemic therapy. It's important for women to understand that if they're going to undergo local therapy with estrogen or DHEA, it needs to be long-term and ongoing. It's not just you treat it and stop. It's long-going treatment. And it's also important that women who are on systemic estrogens understand, and providers understand, that many times these estradiol levels that we get aren't high enough to hit the vagina and vulva, so that women will many times not only need systemic therapy, but will also need local therapy. And super important to also counsel patients that they're not going to get too much estrogen with a local therapy. Local therapies are ultra low dose, range from ultra low dose to low dose. And again, this is here largely for your reference in the future. Vagifem and Imvexxy are suppositories. Creams, which can be messy for some, but hit the lower vagina a little bit better, are estrase cream and Premarin cream. I usually use a combination for patients. If I use just distally to the vulva and the vagina, and then the Vagifem hits the top part of the vagina, then they don't have messy cream coming out of the vagina all day and all night. So that seems to be a good combination. Other options are a ring and oral therapies. Osphena didn't grab a hold. That's a SERM. Didn't grab a hold too strongly because it has a clotting risk associated with it. Non-hormonal therapies for vasomotor symptoms include SSRIs and SNRIs. Paroxetine is the only FDA-approved medication in this category for hot flashes. Effexor, though, may be highly effective, and it's actually great for women who are on tamoxifen and having hot flashes because it doesn't interfere with the metabolism of tamoxifen. Neurokinin 3 receptor antagonists are our new category of medications and include Veoza. They're highly effective, brand new drug, and we now know also that there's some liver toxicity associated with it. So the key to that is you have to check liver function test every 3 months if you're using Veoza. Oxybutynin, a little bit less effective. Gabapentin also can be effective, and clonidine is super old-fashioned, and some people will respond to it, but a minority of them will. Other therapies for vasomotor symptoms include cognitive behavioral therapy, hypnotherapy, and acupuncture treatment. Yoga has been espoused by some, however, has not been well proven to help with vasomotor symptoms. Supplements, I put the ones up here that have data behind them. Soy isoflavones may be helpful for vasomotor symptoms. Red clover, equiol, which is a derivative from soy, Resin, which is really strongly marketed, which is a pollen extract, actually doesn't have a lot of great data behind it. Black cohosh has some data, and it may be that combinations are more effective. Maybe, combinations of phytoestrogens may be more beneficial. And there's certainly some supplement companies that do combinations for menopause support that may be extremely helpful for women who either want to avoid estrogen or who are not candidates for estrogen therapy. Exercise has been demonstrated to be beneficial, both aerobic and resistance exercise. There's a little controversy about how exercise impacts vasomotor symptoms. We definitely need more research concerning this, but both strength training and aerobic exercise have been shown to be beneficial for some groups. But the optimal exercise prescription and its effectiveness across diverse populations remain areas requiring further research. Non-hormonal therapies for vulvar vaginal atrophy. Again, I put this up here mainly for your information. Moisturizers trap moisture in. They need to be used on an ongoing, regular basis. You can get them at Target, CVS. Replens is one. Reverie is online. Halo-GYN is also in stores. And these are largely hyaluronic acid based or others in terms of the way that they work. Lubricants are used at sex, and they need to be just used at encounters, but moisturizer is super important to highlight to individuals and women that they need to be used on a chronic ongoing basis, just like estrogens and DHEA to the vagina. The goal for the perimenopausal patient, which can be an extremely messy time in terms of estrogen levels going up and down, including cycle control, contraception, and symptom relief. So this is a time where combined oral contraceptive pill may be really beneficial for women who don't have any contraindications. And cyclical menopausal hormone therapy may also be instituted for women during this time period if they don't need contraception. But again, that can get a little messy in terms of background estrogen levels. So a combined oral contraceptive pill is favored by many individuals. Menopause is a universal process for women, but the experience itself will be unique for each individual woman. It's influenced by socioeconomic status, education level, health status, and stress, in addition to race, ethnic, and cultural differences. There are ethnic and cultural differences in energy expenditure, physical activity, calorie and macronutrient intake, food preparation, all of which influence the overall experience of the menopausal transition, including symptoms and physiology. There is a complex relationship between race and ethnicity in the menopause transition. It's dynamic, complex, and warrants deeper investigation. We have so little research related to menopause and perimenopause just across the board, and then we have even less when it comes to racial and ethnic differences. And there's a desperate need for data in this area. There are well-defined differences in menopause across races and ethnicities. Black women will experience a younger age of menopause when compared to white women, and Japanese women, Hispanic women will also experience a lower age of menopause with a median age of 48 years. Cardiometabolic changes may be more significant for Black women and Mexican and Hispanic women. Body habitus changes, while they occur across all populations, they are more subtle and occur in a more subtle fashion for Black women. White women will have a more abrupt kind of change in body habitus, and Japanese and Chinese women have been shown to experience minimal fat mass gain. Insulin resistance is also different in amongst races and ethnicities, and Black women may have a greater metabolic vulnerability at the time of perimenopause and menopause. Vasomotor and psychologic symptoms are two of the primary symptoms of menopause, and also are experienced differently across races. Black women tend to report the highest prevalence of more severe vasomotor symptoms, such as night sweats and hot flashes. And white women tend to report more psychosomatic symptoms, such as mood disturbances and decreased libido. Hispanic women report the largest number of total symptoms, and Asian women report the lowest number of total symptoms. Alterations in sleep characteristics are also different amongst races and ethnicities. Black women may experience increased waking frequency in addition to shorter sleep duration, longer sleep latency, and lower sleep efficiency. Hispanic women tend to experience shorter sleep and lower sleep efficiency, and white women may be more likely to have increased waking frequency alone, basically just waking up between those time periods of 2 to 4 o'clock in the morning. We certainly need more studies related to physiologic changes and symptomatology across races. Transgender individuals also, we need to have more guidance and more information concerning menopause in transgender individuals, because menopause itself for many cultures is not well spoken about. And of course, in this population of individuals is even probably less spoken about. Trans men with ovaries are likely to experience menopause similar to cis women. However, men who are taking testosterone are unlikely to experience menopause symptoms, but if they stop taking testosterone, they may experience menopause symptoms. And again, we need more studies, more guidance, and more ability to help these individuals. I was asked to comment on bioidentical hormone therapy. Bioidentical hormone therapy is largely a marketing term, actually, these are hormones that are made in compounding pharmacies. And are thought to be more natural, but they're not. They're made in a chemical process. Our FDA-approved medications are also bioidentical, where bioidenticals may be super beneficial, and I use them in my practice, but I use them if somebody has a peanut allergy, they can't use oral progesterone, so I use natural compounded progesterone. And also for women who may need more subtle support or really alterations in their dosing, these actually may be very beneficial for women. But across the board, we usually say start with the FDA-approved preparations and then move into these if you need them. And those are two specific areas that I use them for. So what's the future? I've told you that we need a lot more data, we need a lot more studies, but the future really also is delaying ovarian aging. There's a number of investigators who are working on how do we delay ovarian aging to prolong our time to menopause. Rapamycin is a drug that people are beginning to look at. And so this is an area of active investigation in terms of improving ovarian aging. And then I have here some resources that I thought were really important. The 2023 Practitioner's Toolkit for Managing Menopause is great. It's from a very well-known practitioner in Australia. There is an interactive evidence-based algorithm that's online from Canada, which is great. And then, of course, there are reviews. And then, of course, the Menopause Society in the United States, super great resource. They have a lot of great online publications that you can download, PDFs, which are also really great. And I'm going to end here, and I went over my 45 minutes. I'm really sorry, but I could talk about this for hours. And I wanted to make sure that I went over kind of the pearls and tips for prescribing hormone therapy, and to make sure that everybody's aware that hormone therapy for the majority of women under the age of 60 or within 10 years of menopause is also a good option for them, and to be aware of the physiologic changes which occur even before the final menstrual period. Thank you.
Thank you, Dr. Poynor. I really appreciate you elevating our understanding of this transition period for women, and perhaps giving us more confidence to lean into hormonal therapy to support their symptoms. There are a few questions in the chat. If you have time to stay with us for us to
Of course,
get to some of them.
Absolutely.
Autumn, I can't see them all. I see one. How does the presence of cancer risk, BRCA, CHEK2, etc., affect decision making?
So generally, if we consider hormone therapy support okay for individuals who are BRCA positive, especially in women who have had undergone prophylactic oophorectomy, we will usually prescribe hormones up until the age of natural menopause of about 51, actually, even if they haven't had prophylactic mastectomies. I think beyond the age of 51, unless somebody is really having severe symptoms, we usually say, go ahead and stop. Same thing with CHEK2. If somebody's having severe menopausal symptoms, it's not off the table, but making sure that the individual is followed by breast MRIs, ultrasound, mammogram, and having the appropriate follow-up. So not an absolute contraindication by far, but definitely a consideration in terms of stratifying where you're going to put menopausal hormone therapy.
Thank you. What is the role of intravaginal estrogen? Are progestins needed with intravaginal estrogen?
Great question. Love that question. I was actually I think I had that on a slide that I zoomed through, but no. So with intravaginal estrogen, progestins are not needed. And it's really important to understand that intravaginal estrogens are many times also required if you're on systemic estrogen. So always important to ask individuals if they're still having dyspareunia. But no, progesterone or progestins are not required with intravaginal vaginal estrogen or DHEA. There's another hormone on the market, Intrarosa, which is DHEA, which also does not require progestin progestogen support.
For perimenopausal patients that have an hormonal IUD in place, do you prescribe estrogen replacement alone, as the IUD is providing endometrial protection?
So IUDs are not FDA approved for endometrial protection, but definitely a Mirena IUD will, up until about 5 years. I know it's approved for contraception up to 7. I usually use it for 5 years for endometrial protection. So totally fine to use estrogen alone for individuals with an IUD, whether it's a Mirena or Skyla or other hormone-containing IUD. The only caveat to that is the woman who's having sleep issues or ongoing vasomotor symptoms. Because if you have a good estrogen level and you're still having sleep issues, you may want to consider oral progesterone on top of that, because the metabolites that are thrown off from oral progesterone are somnolence inducing. So totally a reasonable management strategy to use estrogen with an IUD, but be aware of the individual who has ongoing vasomotor symptoms or ongoing sleep disruption. You may want to add in a natural progesterone on top of that, and you can certainly do that. And that's something that you can do for a woman who requires the IUD for contraception also.
And one more question, please. Can you comment on tibolone for hormone replacement therapy?
Tibolone is, I'm not so familiar with tibolone. Tibolone is used more in Europe than it's used in the United States, and it's super synthetic also. So the safety data in terms of transdermal estrogen is much safer in terms of thromboembolic risk than an oral type of hormonal medication. So I tend to default to the transdermal oral progesterone, and tibolone is not widely used in the United States.
Thank you. Thank you, Dr. Poynor. Dr. Poynor has graciously agreed to share her slides with us, and we can make it more widely available to our audience. There's a lot of excitement in the chat about this conversation that we're having. So thank you, Dr. Elizabeth Poynor. We really appreciate you being part of our grand rounds for the Mount Sinai Department of Family Health. Thank you very much.
Thank you so much.